So today we're joined by Tiarnan Keenan from the National Eye Institute. Tiarnan is a Statman investigator in retinal disease at the National Eye Institute, National Institutes of Health in Bethesda, Maryland. He received his undergraduate and medical degrees at the University of Oxford and completed integrated academic clinical training in ophthalmology and biomedical research, predominantly at the Manchester Royal Eye Hospital and the Oxford Eye Hospital. He was awarded a PhD at the University of Manchester for biochemical analysis of human macular tissue in relation to age-related macular degeneration, and as a Fulbright scholar at the Moran Eye Center at the University of Utah, he conducted postgraduate research into the genetics and mechanisms of AMD. He joined the National Eye Institute in 2016, where his main clinical and research interests are focused on diagnostic, preventative, and treatment approaches to AMD. Tiarnan will be talking about his recent research, which shows that in age-related macular degeneration, AREDS2 supplements slow down the progression of geographic atrophy. And he's also going to cover his related research on how a healthy diet is important for slowing down the progression of AMD at all its stages, both early and late. So I'm going to hand you over now to Tiarnan.
Yeah, thank you so much for that invitation. And so yeah, I'm Tiarnan Keenan. I'm a clinician scientist. So I've been at the National Eye Institute in the US for about 7 or 8 years now. But prior to that, all of my my clinical and academic training was back in the UK. And of course, during that time, I was really aware of all the fantastic work done by the Macular Society. So it's a real privilege to be able to come and speak to you all on their behalf. So yeah, on the clinical side, I see patients with, retinal disease with a bit of a focus on age-related macular degeneration. And then similarly on the research side, my main research focus, as we were hearing a second ago, is also on age-related macular degeneration. I'm just going to share my slides. So yeah, if you give me 1 second. Okay. Great. So I hope you can see that okay, for those of you able to see. But I will say on the slide front, these are more just for my own benefit, my own kind of memory to keep me going in order through the presentation, the things I was, hoping to cover. So I'll do my absolute best to, to describe everything on the slides, particularly all the important points. And the other thing I should mention, I have no conflicts of interest to disclose. Yeah, so the organizers asked if I might be able to say a few words about my recent research, trying to answer the question whether or not the AREDS2 supplements that I think most people are pretty aware of, whether they might actually be helpful even later in the course of AMD than we previously thought, so specifically at the stage of geographic atrophy or advanced dry disease. So I was going to focus on that, and but then, as we were hearing a second ago, also say a few words about diet in macular degeneration, because of course diet and oral supplementation are closely related, and there are times that we need both of them. There are times sometimes when one or the other is sufficient.
And Tiarnan, just to say, for some reason, we can see the main slide and the next slide and your notes.
Oh, sure.
So I'm not sure if something weird has happened with your display settings.
Yeah. Does that work now?
Yes, marvelous. Thank you so much.
Okay, brilliant. Yeah, no, thanks for that. So on the supplement side of things, here I've put on this slide a kind of take-home message just to try and encapsulate the main research I was going to try and cover. So I'll just go over that briefly, and then because it is quite complex, I'll maybe go back to the beginning and try and set the scene and work back towards this. But essentially, the idea was that the research suggests that for people with geographic atrophy that's still non-central, it hasn't yet involved the central macula. So the findings suggest that the AREDS2 supplements actually slow down the rate of expansion of the atrophy, but slow it down specifically towards the macular center point. Of course, that really important part of the central macula that's responsible for our high acuity vision. And they slow it down by quite a large amount, it seems, by as much as about 55% or so. And it seems to relate to this phenomenon of foveal sparing, and I'll kind of introduce that concept and return to it in a minute. That's to try and encapsulate the message in a nutshell. And at this point now, I'll just start back at the beginning, give a little bit of background, and then work through the recent research. So I'm showing a slide here that has color photographs of individuals at different stages of age-related macular degeneration. And so going from the from the left to the right of the slide, we see a picture of someone with early disease. And then over the course of years, or even kind of a decade or more, that might progress to the point of intermediate AMD. But during early and intermediate AMD, typically, visual symptoms are going to be either absent or relatively mild. And then from intermediate disease, unfortunately, that can progress again over years or even a decade or more to advanced disease. And it's at that stage of advanced disease, of course, when symptoms, suddenly become very significant in many cases. And I think, as most people know, that advanced disease can have two different forms or subtypes. It has the well-known wet form, also called neovascular AMD. And of course, that's the one that has to be diagnosed really quickly. And you have to get access, very rapidly to anti-VEGF injections. I'm not going to talk about that so much today. But the other form of advanced disease is, of course, the advanced dry form, also known as geographic atrophy. And when that first arises, usually you get a tiny, roughly circular little patch of degeneration. And unfortunately, in that little area of the macula, the photoreceptors have degenerated and kind of died and can't come back. So there's a tiny little blank spot in the vision. Luckily, it doesn't usually occur at the very central macula. In the majority of cases, it's away from the center. And then once that comes, there's a tiny little spot or a few spots. Unfortunately, those patches of degeneration kind of expand across the macula, taking more and more of that central visual field with them, and often then, affecting the central vision in time. On the plus side, it's usually very slow, that rate of degeneration, taking many years or even a decade or more to cover the whole macula. And I've just got a few slides for those who are able to see them of some images of the back of the right eye with an individual from our clinic who already has quite decent sized geographic atrophy and unfortunately already affecting the central macula. But essentially, we re-imaged that individual over the course of 2 or 3 years. And so if we go through those images, essentially, and going back in time now, we can see that it's a bit like a brush fire. The area of degeneration slowly expands. And it is very slow. It is over the course of multiple years, but it kind of slowly but surely increases, as I say, taking more and more of the central visual field with it. Okay, so I'm just going back to the slide where I was showing the different stages of AMD from early to intermediate to advanced, and that additional stage of geographic atrophy progression or expansion. But on the slide this time, I've added in some text in red, just highlighting the stages and forms for which we know AREDS2 supplements are helpful. And so specifically from the AREDS1 and the AREDS2 studies, we know that the supplements are really helpful at the stage of intermediate AMD. And the additional scenario where they're helpful is, let's say, if you have advanced disease in one eye, but not yet in the other. That's the second scenario where we have really good evidence that the supplements are helpful and they decrease the risk of progression to the advanced disease by about 25% or so. I maybe won't get into it too much, but if we look carefully at the study results, it turns out they're actually much better at decreasing the risk of progression to the advanced wet form and much, much less at decreasing the risk of geographic atrophy occurring in the first place. But broadly speaking, considering both forms, they decrease the risk by overall about 25%. And so a couple of other things follow from that. For individuals with early AMD, or let's say someone with a family history of AMD, but no signs yet in that person's own eye, we do not have evidence that the supplements are helpful. Equally, on the other end of the spectrum, for people who already have geographic atrophy, let's say, some geographic atrophy in both eyes, again, we never had any evidence that they were helpful or harmful. So, some people who've been on them, if they develop geographic atrophy, some people might stop, others might continue. But we'd never really looked in detail before at whether or not they might be helpful at that very late stage. And so that was the focus of my recent set of analyses. I wanted to try and address that question. Because from AREDS1 and AREDS2 studies, these, of course, are great, really large randomized clinical trials. So randomizing individuals either to the real supplements or to the placebo. And so we can actually look for geographic atrophy as well, which we hadn't done before. Oh, and I'm just showing again an image of an individual with geographic atrophy, where we go, forward over 2 or 3 years and see that patch of degeneration increasing. And it's just to remind me to say, that the main metric used, in clinical trials or analyses to try and understand the rate of geographic atrophy progression or expansion, the main metric is usually just a simple area metric. We just measure the area of the patch of geographic atrophy, and we see, the rate at which that increases over time. And if you give a treatment, is it slower in the people to whom you gave the treatment versus the placebo? But actually, I think there's more to geographic atrophy than area alone, particularly if we're thinking about individuals with geographic atrophy that doesn't yet involve the center. And so here I'm showing an image in this slide of someone with geographic atrophy with a small early patch of degeneration. And luckily, it's away from the center. And if we see over the course of 2 or 3 years how that behaves, it kind of increases in size. And so it gets a little bit closer to the center. But it turns out that expansion at or near the center in some people, maybe even most people, is actually much, much slower than expansion of geographic atrophy elsewhere, as much as maybe 3 or 4 times slower. And this can lead to kind of interesting and useful configurations, different shapes of geographic atrophy. So here I'm showing an individual, it's a simple color photograph of the back of the eye. And essentially from the left to the right, we're going forward in time over the course of 4 years. And so on the left, there are patches of geographic atrophy kind of shown in white, but luckily not yet involving the very central macula. But then if we go forward in time, we see there's expansion of the geographic atrophy in most directions, but actually much, much slower expansion of the atrophy towards the center. And so the atrophy is kind of wrapping around the central macula, and it can lead to kind of horseshoe or later on even kind of full donut configurations, but still sparing the center. And these are really beneficial properties of the central macula in a way, because if that central portion is still working, typically individuals still have really good visual acuity and pretty decent visual function. So it would be great in a sense if we could, encourage or augment this phenomenon of foveal sparing in geographic atrophy to keep people in these configurations, even if we can't slow expansion elsewhere in the macula. And so that's a long way of introducing foveal sparing, this interesting phenomenon, and of saying that I wanted to use not just an area metric in these analyses, but also use a second metric where we kind of plot the rate, of expansion to the macular center point. Is it faster or slower? And that turned out to be really important, as I'll come to in a minute. So I'm just showing slides of this individual with non-central geographic atrophy again, and we can plot the rate at which it progresses to the center, and that will be faster in some individuals and slower in others for reasons that we don't fully understand. Okay, so I was going to move on to the results themselves. I'm going to try and keep it relatively simple and high level. So I'm just showing a slide with the way that the randomization was done in the AREDS-1 study. So to try not to make it too complex, I think we can think about it as essentially taking a large pool of people and randomly assigning half of them to the real oral supplements, and then the other half randomly assigned to placebo. And then we can see how the macular degeneration or the geographic atrophy progresses over time, and we can see if it progresses more slowly in the people who were randomly assigned to the active supplements. And it turns out in AREDS-1, there were about 400 individuals, or 400 eyes, I should say, with geographic atrophy. So it's a pretty decent number, giving us good power to do these kind of analyses. And I'm showing a slide with some numbers and statistics. I don't think we need to worry about too much. The main message from these is if we look in AREDS-1 at all the individuals with geographic atrophy, and we use that traditional area metric, essentially we don't see any significant treatment effect from the AREDS-1 supplements. But instead, it's much more interesting if we focus on the people who have geographic atrophy that hasn't yet involved the center, so non-central GA. And instead, we focus on that rate of expansion to the center that I was talking about earlier. And all of a sudden, we do see a treatment effect, and a pretty decent sized treatment effect for the AREDS-1 supplement. Specifically, as it happens, it's for the antioxidant component of that, vitamin C, vitamin E. But to keep it simple, we can just think of the AREDS-1 supplement slowing down the rate of expansion of GA to the center point by as much as about 1/3, about 35%. And so that was the first kind of really exciting and interesting finding. There's a lot of other analyses I'm not going to dwell on too much. But instead, we can do the same kind of thing in a later separate study, in the ARIDS2 study. And that was even larger. For geographic atrophy, it had as many as about 1,200 eyes. And again, we can see how they grow over time, and we can relate that back to the randomization. And this time, in ARIDS2, it's a little more complex, but essentially, all of the individuals in ARIDS2 were already taking the ARIDS1 supplements because they had been previously shown in that first study to be effective for earlier stages of AMD. But then on top of that, there was a randomization where essentially half of the participants were randomly assigned to take lutein zeaxanthin supplements in addition. And then the other half were randomly assigned to just take placebo supplements, plus, of course, the ARIDS1 supplements. So sorry, a little complex in the design, but that's the structure of it. And again, I'm showing some numbers and statistics that I don't think matter too much. Just to just give verbally the main results. Essentially, in ARIDS2, I saw the same kind of pattern. So if we look at that traditional area metric, we don't see any significant treatment effect from the lutein zeaxanthin. But instead, if we focus on those individuals with non-center involving geographic atrophy, and we look at that rate of expansion to the center, suddenly we do see a treatment effect again from lutein zeaxanthin this time. And again, it's pretty large in the order of about 35%. And it's on top of the previous treatment effect I mentioned, because of course, all of these individuals are also taking those ARIDS1 supplements. So I apologize for the bit of complexity there, but just that's what the data looked like. And now to try and synthesize that, all of these components that I've been talking about, both the ARIDS1 antioxidants plus the ARIDS2 lutein zeaxanthin, all of them are contained in the modern ARIDS2 supplement that, that's been on sale for many years or even kind of a couple of decades now. And so cumulatively, those supplements should be slowing the expansion of non-central geographic atrophy by as much as about 55%. So by, a little over half. And it seems to be that they're kind of restoring or augmenting this phenomenon of foveal sparing, which we see in some individuals, but not necessarily all individuals. So that foveal sparing, it's kind of like that central area of the macula is kind of warding off the atrophy from kind of, incurring into it. And it's kind of warding it off much more strongly in people who are taking these ARIDS2 supplements. There's other things to say about the supplements. Probably, you've heard a lot about some recent trials of injectable medications, given into the eye every month or every 2 months to try and slow down the rate of geographic atrophy that have been approved in the US, but not necessarily in Europe. In contrast with those, these supplements are something very, very simple. Oral administration, very low cost, although sadly, of course, that cost is often borne by the individuals themselves. And a really good safety profile, that both from the trials themselves and then from the fact they've been used in the ophthalmology community for 10, 20 years now, we know that they're really safe, these supplements. So in the way, the bar is a little bit lower compared to, something that needs to be injected in the eye. I will say that, these studies, the ARIDS1 and 2 studies, were not specifically designed to look at this question of geographic atrophy expansion. So the analyses are really robust because we go back to randomization, but the studies were not designed to do that. So we are hoping in the next couple of years to launch dedicated new study to try and, look again at this question to really confirm that that is absolutely the case and to get the most accurate, measurement of the treatment effect. But in the meantime, given that there's such a good safety record and there's such low cost, I would already recommend this approach, particularly for individuals who have geographic atrophy not yet involving the central macula. There's very little to lose, essentially. And we even had some signs from the studies that it may help preserve visual acuity for longer, although really for that, you need a very, very long study. So just to try and summarize that in a diagram, for those that are able to see this, I'm just putting up again the diagram with different stages of AMD from early to intermediate to advanced. And again, superimposing on that the stages and types for which we know supplements are indicated or helpful. So as I said before, we've known for a long time that for intermediate AMD, or for advanced disease in one eye but not the other. The supplements are definitely indicated to decrease the risk of developing advanced AMD. But then what this new study adds is they're also helpful, it seems, even in a later stage, even once geographic atrophy has already occurred, and particularly for individuals where it's not yet involving the center. So just to return to that take-home message, so essentially the research suggests that in non-center involving geographic atrophy, the modern AREDS2 supplements slow the rate of expansion to the center point by as much as about 55%, seemingly by kind of enhancing foveal sparing. And that's probably as much, as I was going to say on the supplement side of things for that very recent research. And then if we have a few minutes, I could say a word about diet, because as I say, we often think about diet and supplements alongside each other. That can get a little complex. But then, of course, I want to make sure we have plenty of time for questions. Okay, so on the diet side, I'm just putting up a slide here that's entitled The Mediterranean Diet and Progression to Late AMD in the AREDS1 and AREDS2 studies. Because in the AREDS1 and AREDS2, we, they were randomized trials of oral supplements. We definitely weren't randomizing people to different diets, but we definitely collected a lot of dietary information and have done all kinds of analyses to try and see, whether or not a healthy diet of this kind or that kind may be useful in slowing down disease progression. But it's just taking people's diet as they came, not making any recommendations or randomizations as part of the study itself. So, in these particular analyses, we chose to focus on the Mediterranean diet because that's attracted a lot of attention for, benefits in cardiovascular disease or cancer or neurodegenerative disease. But I will say, you could probably say much the same thing of other healthy eating patterns. The Mediterranean diet has actually a lot in common with like a low glycemic index diet or with a predominantly plant-based diet. Those all have much, much more in common with each other than differences between them. But if we're going to focus on the Mediterranean diet, I'm just putting up a slide here with some images of what we might see if we put that into a search term. Images of fish and fruit and vegetables. So Mediterranean diet tends to mean a really strong emphasis, of course, on fruit, on vegetables, on whole grains, on nuts and legumes. In oil and lipid terms, it means much more in the way of olive oil and oil from avocados and plants, and much, much less in the way from meat and other animal products. In terms of meat, it usually means only a very rare red meat, but white meat is okay, and then a bit of an emphasis on fish as well, of course, ideally twice a week. So I won't dwell on this too much, but I'm just putting up a slide where it gives details of the 9 specific components that are kind of defined as making up the Mediterranean diet. So it's those things I was mentioning before, fruits, vegetables, whole grains, nuts, legumes, less red meat, more fish, and so on. And so that's the way in which we analyze people's diets in the AREDS1 and AREDS2 studies. But just to to cut a long story short, essentially in both of those studies, we found that a healthy diet, in this case, more Mediterranean type diet, was very, very strongly associated with slower risk or slower rate of progression from intermediate disease to advanced disease. So for example, taking the 1/3 of people who happen to have the least healthy diets and comparing those to the 1/3 who had the most healthy diets, the most Mediterranean diets, the difference in the rate of progression of disease to advanced disease was as much as about 25%, even if you adjust for, lots of things that are associated with diet, like smoking and body mass index and so on. So diet seems to be really important at that stage of intermediate AMD onwards. And then I'm showing a slide which tries to delve into, well, a couple of things. Firstly, is a healthy diet, in this case, a Mediterranean diet, is it helpful for decreasing the risk of both advanced forms, wet and dry? And secondly, that brings a second question of what does it mean to have a healthy diet and supplements, or one versus the other? And so we were saying earlier that we have really good evidence that the AREDS2 supplements are great at decreasing the risk of developing wet AMD, but sadly, much, much less good. They sadly do almost nothing to decrease the risk of developing advanced dry disease, geographic atrophy. Well, interestingly, it's almost exactly the opposite situation for a healthy diet. So a healthy diet is really strongly associated with decreased risk of developing geographic atrophy in the first place. and a little bit less so with the risk of developing wet AMD. And this is why I've underlined some text in this slide saying, a healthy diet and oral supplements have complementary benefits. Some patients might say to me, I take the AWIDS2 supplement, so it doesn't really matter what my diet is, and that's not the case. And some others might even say, my diet's really, really healthy, so I don't think I need the supplements. And equally, that's not the case. It turns out that each of them, diet and supplements, are preferentially targeting each of the two advanced disease subtypes. So to decrease your overall risk, you really need to be doing both of them. So definitely for intermediate AMD or for one eye with advanced AMD and the other does not yet, I'd really strongly recommend both of these things in conjunction. As I say, they're complementary. We can ask the question, let's say I have intermediate AMD, I want to decrease my risk of advanced AMD. I can try and adhere to a Mediterranean type diet, but is it the case that some parts of that are more important than others? Or like cardiovascular disease, are they each kind of equally important? When we do those analyses in AWIDS 1 and 2, it turns out that there are some things that really stand out as far more important. The one that stands out the most by far is fish. So regular fish intake, ideally, twice a week, seems to be really important in decreasing the risk of developing advanced AMD, particularly geographic atrophy. And then the second one that stands out next is regular intake of fresh vegetables. So we can start to build up kind of, tailored nutritional advice, kind of stage-specific nutritional advice for different stages of AMD. The intermediate AMD stage, it seems that fish and then secondarily vegetables, amidst all the other components of the Mediterranean diet, are the most important. And I'll just move on quickly in the interest of time. One difference with supplements, let's say someone has only early AMD. We know supplements that are not necessarily beneficial at that stage. We don't have evidence for that, but we do have evidence that a healthy diet is helpful at that stage. So people with healthier diets have significantly slower rate of progression to intermediate and subsequent disease forms. So we start to build up a picture of which stages, diet versus supplements versus both are helpful. And so I'm putting up a slide that summarizes this for diet. We have the different stages from early to intermediate to advanced again. And basically, it turns out that diet is really helpful at all stages, even early when supplements are not necessarily indicated. And the last thing I'll mention just very briefly is, what about that last stage? Again, a bit like the supplements, what about when we already have geographic atrophy? Surely diet's probably not important then. We always had the idea that once geographic atrophy comes, it just expands at this constant rate. So we also analyzed geographic atrophy expansion according to diet. And I'm just showing, again, some detailed numbers and statistics, but the overall message from that is that even if you have geographic atrophy, a healthy diet still seems to make a difference. So people who had healthier, more Mediterranean diets, they had significantly slower geographic atrophy expansion. And this was using the area metric, just expansion anywhere in the macula, even when we adjust for other things like, again, smoking and so on. So we can do the same thing again and ask which components are most important. Is it fish and vegetables again? At this stage, it's actually something different. The biology seems to be different at this stage. The things that stand out most now are definitely more fruit, less red meat, avoiding excess alcohol. Those are probably the three most important things. So really regular fruit intake and less red meat seem to be really, really strongly associated with slower expansion of geographic atrophy. So diet is important even, at the late stage and even at the early stage I mentioned. So I have a slide here with the different stages of AMD with the title, It's Never Too Early or Too Late, to adopt a healthy diet in macular degeneration. It's important much earlier and much later than we originally thought it might be. And I have just one final summary slide here, superimposing everything that I've mentioned for both diet and supplements at all of these different stages. So the main message is that early AMD, diet's really important, but supplements are not yet indicated. Intermediate AMD, they're both really important. They're complementary because each one preferentially targets one of the two advanced disease subtypes. And then as we were hearing, even once geographic atrophy is there, diet and supplements are both important, both for expansion overall and for those AWIDS2 supplements also really, seemingly quite a large effect in slowing expansion, specifically into the macular center. Great. So it's a lot of information there. I hope that was helpful. I'm really pleased to be able to answer any questions that I can on any of that or related things. I'll probably stop sharing my slides at
Brilliant.
that point.
Tiernan, thank you so much. It's that story again, isn't it? The Mediterranean diet. It
Right.
helps in so many areas, although fascinating to see the difference in the food groups in terms of early or if you're intermediate or later stage, that the fruit at the beginning, and then when we talk about fish, we talk about oily fish, don't we? It's particularly
Right. That's
the
true.
omega-3 of oily fish, isn't it? Yeah.
Yeah. And yeah, I've done a lot of different analyses. These seem to be genuine, stage specific differences, probably pointing
Mm.
to the fact that slightly different biology is operating at different stages, and you can preferentially target that with slightly different approaches, antioxidant versus other. Yeah.
Yeah. So we're getting asked the question a lot, and I'm gonna attempt to go back through them all. Thank you all, everybody, for there's some great questions in the chat. So one of the questions is particularly around how do I know if I'm buying the right supplement? So how would somebody know if what they're buying is the AREDS2 formulation?
Right. No, that's a great question. I mean, definitely in the US, and I think it's the same in the UK, essentially, if it says AREDS2 formulation and it has the little, there's a little kind of icon that's a bit similar to some of the ones that was on my slides, kind of circular diagram. But if it says AREDS2 formulation, then you should be safe. Because of course, yeah, it's marketed by different companies under different names. But any of those that say AREDS2 formulation, it should be fine.
Yeah.
I mean, I
Yeah.
don't know if I can list the specific components, but yeah,
Well,
if it says,
I've put the components in the chat,
oh,
and
great, fantastic, yeah,
our our experiences everywhere from Amazon, Holland and
right,
Barrett, Boots, Superdrug, anywhere you buy any kind of vitamin will sell the AREDS2 supplements. And I've seen a lady's put in the chat that actually she's had hers prescribed by her GP, which
right,
is fabulous. So I think if you can get that, then
yeah.
absolutely go for that. And so you're really saying, aren't you, that actually the supplements. So if, for example, we know there's often a family link, isn't there, with AMD. If
Right.
if I was as an older placer had AMD and I had children and grandchildren, am I right in thinking you're not saying to get them to take the AREDS to almost kind of prevent? They absolutely should have the Mediterranean diet, but you wouldn't, or would you recommend that you've got family members to also take it if you have AMD?
Um, yeah, so if someone who has a family member affected by AMD, but himself or herself does not yet have, let's say, intermediate AMD, or has either early AMD or no sign of AMD, we don't have any evidence that supplements are helpful at that stage. I mean, and I don't know, it's partly because it would be extremely difficult to design and execute a trial that would be able to address that question. It would have to be an absolutely gigantic trial because the kind of event rate, the progression rate would be so small, and you would have to, depending on the age group of the participants, wait 10, 20 years.
Yeah.
So we don't have any evidence in family members that there's anything to be gained by oral supplement
Okay.
use. But
No.
on the other hand, diet, probably would be beneficial.
Yes, yes. Eat that Mediterranean diet, eat the rainbow. And we know a lot of people will get told there's nothing more we can do. We're absolutely saying to those people, aren't we, take the AREDS2 formulation, even if you can't have active treatment now, the AREDS2 would still be beneficial.
Um, yeah, so and depending a little bit on what stage, so I guess it has to be a little bit individualistic, but I would say someone with geographic atrophy, definitely if it's non-central, I would really recommend the AREDS2 supplements. Even if it's involving, most or all of the center, I feel like there's not too much to lose by taking the supplements, and a diet still would be helpful in slowing the rate of expansion in the, more towards the edges of the macula. Um, of course, if the geographic atrophy is so far advanced that it's occupying the whole macula in both eyes, supplements or anything like that are not really going to be helpful. Similarly, if someone has really advanced neovascular or wet AMD in both eyes with, very prominent scarring. It's the same kind of situation where unfortunately no treatments are going to be particularly helpful at that stage, short of, low visual aid type approaches.
Yeah. Um, there's quite a few questions regarding the amount of zinc in
Oh yeah,
ARIDS2, and it can be a problem for some people. And I know we had a question in advance from somebody who has osteoporosis, and they are taking calcium, and there's a worry that zinc affects calcium absorption. I don't know if are you able
yeah,
to comment on
yeah.
that?
Yeah, no, that comes up often, the zinc question. So um, in the original ARIDS-1 study, it was a pretty high level of zinc, 80 milligrams given daily, that was shown to be effective. In ARIDS-2, it wasn't the main aim, but there was a secondary aim to try and see what would it mean to have 25 milligrams instead of 80. So there was a secondary randomization to a lower dose of zinc at 25. There was no significant difference between the two. So in some people's eyes, that can justify a slightly lower dose of zinc at 25 milligrams. Although for the ARIDS-2 formulation retained the high dose of 80 milligrams, because the highest level of evidence had come from ARIDS-1 to show that was effective. I think, but as you say, some people, might have difficulties in tolerating that high levels of zinc. It tends to be like in the US, I think people and agencies and so on are slightly more comfortable with high levels of zinc, a little bit less so in Europe. I mean, no official position or anything, but I personally would say that I think, particularly for those who can only tolerate lower levels of zinc, I don't think you lose too much in intermediate AMD by having that lower dose of 25 milligrams. And I know there are a lot of different options. Like, there will be some brand with some named product, but then there'll be like maybe 2 or 3 different variations on that. One will be lowering the zinc, one might be adding in a different carotenoid, one might be adding in omega-3 fatty acids. So I would try and stay as close to the ARIDS-2 formulation as possible. But if one needed to decrease the zinc dose to 25 instead of 80, I don't think it's the end of the world. Oh, and then sorry, you had the second part of the question. I think, yeah, there can be some competition, I believe, for intestinal absorption of these different minerals, zinc and calcium. Yeah, so there is some competition. So if you're taking a lot of one, the absorption of the other might be lower. There are ways to try to deal with that, mostly related to the timing of the supplements. So like, I think to increase calcium absorption, you can take it in smaller doses broken up in between meal times. And then maybe you could take, the ARIDS-2 supplement with food. You could do something like that. If you absorb a little bit less zinc, I don't think it's the end of the world again.
No. And Tiarnan, do you know, has there been any research into the supplements and other macular conditions? So, some of the inherited myopic macular, is there any evidence that it's also beneficial for some of those conditions?
Yeah, much, much less. And so, maybe there are some things that we can think about by extrapolation, but the level of evidence is far, far less. I mean, I'd say, and it's not so much in my area, but some of the inherited retinal, diseases and dystrophies like retinitis pigmentosa conditions, that's probably the next area where there's been a little bit of research, but nothing quite on the scale of ARIDS-1 and ARIDS-2. So, and I think there've been some reanalyses in the past, year or so. And I think even at the American Academy of Ophthalmology meeting, there was a recent paper presented trying to look at evidence behind nutritional supplementation for conditions like retinitis pigmentosa. And I think they're publishing that paper in the coming few months. Question like revisiting the role of vitamin A. So I think people often, for other conditions, often do tend to take some of these supplements, but in general, there's very little evidence for it.
Yeah, yeah. Presumably the same is true. So, somebody's asked the question here, older people are likely to have had the least processed food with lots of veg, yet there is a high number with macular degeneration. Is there likely to be an explosion with the next generations? You've talked, haven't you, about how
Yeah.
diet is clearly playing a role in progression. Might we discover that actually there is an element of diet that could be causing it in the first place?
Yeah, no, that's a great point. And yeah, I think there are two parts to that. Changes over time. in diet and how that can relate to changes over time in the frequency and severity of macular degeneration, and then even differences between countries. For example, in many Asian countries like Japan, they have a lot of AMD in general, but dramatically less geographic atrophy, like really, really massively less, for reasons that are not clear, that don't seem to relate necessarily to genetics. I mean, maybe it's a coincidence. Of course, they tend to have very healthy diets with a lot of fish intake. It's tempting to wonder if that has been protecting them. Despite the genetic load of AMD, they have an equal amount of neovascular or wet AMD, but much, much less geographic atrophy. There may be other factors to it. There have not been many. There's been one study trying to track AMD prevalence over time, and like repeated examinations of the Beaver Dam participants in in the United States. It's difficult analysis to do, but it was suggesting like subsequent generations, the frequency and severity of AMD is actually declining a little bit. But that may be to do with general improvements in health, sanitation, all kinds of things, even if our diet is getting a little bit worse. But diet is very clearly linked to AMD. So anything we can do to improve that will be improving the burden of disease for subsequent years and decades.
Yeah. And Tiernan and I were talking before we started about, we know the challenges that the NHS are having, and we're hoping that there'll be a treatment for dry AMD. And what does that mean for people going into clinics? And actually, there is something isn't there, in that this is a relatively inexpensive way of slowing that progression that could then, help in some way some of the stress on the NHS.
Absolutely. So in that respect, I feel like definitely nutrition and perhaps supplements as well. It's a kind of public health issue. Maybe some might, but most pharmaceutical companies are not going to be talking a lot or doing research into nutritional things. But in terms of having a massive impact globally on populations and in public health, I think that they can have almost much more powerful effects, than very individual, often quite expensive treatments, requiring quite a significant burden on the individual and on the health system.
Yeah.
So yeah, and often having health benefits across multiple organ systems, not just one. So it has that,
we know
benefits.
It's so good for everything, don't we? The Mediterranean diet. There are, heart disease, stroke. It's what we get told over and over again, and there is so much building evidence now, isn't there, in terms of how to help you have a healthy aging.
But it's tough. I mean, I know it's tough, and maybe people get bored hearing about it, but it's all the kind of boring things like exercise, diet, not smoking, and so on. They have a massive impact on many systems, but it's not necessarily easy. But I feel like at least we have some indicators from these analyses of particular things that individuals can focus on, let's say fish or, fruit, according to their particular type and stage of AMD. If it seems too daunting to just kind of adopt. But because we saw big differences, even with modest differences in diet, we saw big differences in the rate of progression. You don't have to be perfect, I think. Yeah.
Which is good, because I'm not sure how many of us are. Margaret's asked, she says, what is the actual difference between neovascular and geographic atrophy?
Yeah, just kind of anatomically in the eye, they're quite different. So for neovascular or wet AMD, essentially what happens is there's a kind of growth of abnormal blood vessels through a little membrane that should usually keep the blood vessels on the other side of it. So a growth of blood vessels, a kind of membrane of blood vessels that then comes to sit underneath, or sometimes even within the retina. And blood vessels shouldn't be there. They're going to disturb the really delicate architecture of the retina. Because they're immature blood vessels, they're going to be leaking fluids. They might leak blood, which is toxic to the retina, and they bring with them cells that set up scar tissue formation. And so, of course, then the anti-VEGF injections, they don't necessarily get rid of the membrane of abnormal blood vessels in most cases, but they're very potent at kind of controlling the leakage and the bleeding, and sometimes some of the scarring associated with wet AMD. So, and then geographic atrophy is very different. There are no blood vessels that have kind of come through to be where they shouldn't be. Instead, it's the case that some of the cells, like the photoreceptors that act like the film in the back of a camera, or their supporting cells, the so-called retinal pigment epithelial cells, that kind of complex has degenerated and died for reasons that are not well understood. And then for whatever set up that patch of degeneration, it seems to then spread like kind of dominoes spreading in all directions. It sets up this brush fire of degeneration. And patches where geographic atrophy has occurred, light falling onto that is not seen by the eye and the brain, so you get a blank patch. So different processes anatomically, we have some understanding of them, but an imperfect understanding, I'd say.
Brilliant, thank you.
And then they can, when it gets, yeah, sorry.
No, keep going.
I was just going to say one complicated thing these days is that increasingly we see individuals where they have both forms in the same eye. I mean, typically one will have come first, but if you have wet AMD and you treat it successfully and for long enough, it can be that elsewhere in the macula you get patches of geographic atrophy coming as well. So that can be disappointing. You can even have both subtypes in the same eye.
Blimey. There's a couple of people asking, and you may not know the answer to these questions, but are there supplements that could potentially help with either the blurry vision or that waviness in the eye?
I presume they're meaning caused by age-related macular degeneration.
Yes, yeah.
So it kind of depends what. So waviness in the eye, where lines that should be straight are a bit kind of wonky and wavy, or
Yes, the fun of looking at the Amsler grid.
Right. So that can often be a really useful warning symptom to suggest that wet AMD might be there. Maybe it represents some fluid leakage from wet AMD, and to go very quickly and to have an eye examination, and if there is wet AMD there, to start treatment. It's kind of a difficult situation. There are times when if you start the treatment with anti-VEGF injections and you get rid of the fluid, that distortion, those wavy lines may disappear. But other situations where maybe they might improve but not disappear completely, because maybe there's some residual waviness in some of the architecture of the retina that you can't really get rid of. So yeah, supplements unfortunately are not going to help at all with that situation. The best one could do if wet AMD is there is to have aggressive treatment with anti-VEGF therapy. Yeah, occasionally, as I say, unfortunately, there might be residual waviness. And it's slightly different, but you can maybe even have a degree of waviness with patches of geographic atrophy, because the image can kind of, maybe it's disappearing in the middle, but the edges it's kind of falling away. And again, that's not something that supplements can help with in the short term.
Brilliant. And is the same? So you were saying, weren't you, that the evidence is saying the supplements, you don't start them at the beginning. The beginning is the diet bit. So presumably if somebody's been to the optician, they've had an OCT, and the optician has said, oh, I can see some drusen on the scan, according to the research, is that too early to be then starting the AREDs? Actually, that's the point where you should be thinking about your diet really seriously.
Right. Yeah, so then it all comes down to the kind of the size and the degree of drusen, and then there are these different thresholds for sizing. So if they're so-called small drusen, that isn't necessarily even defined as AMD. So if it were me, I would probably try and adopt a really healthy diet and lifestyle there and not smoke and so on. If the drusen on the scan are a bit bigger, so they have medium-sized drusen, then that would count as early AMD. And that would be the same. Diet is really important then, but supplements are not yet indicated. If they're larger still and sometimes accompanied by other kind of high-risk characteristics, then that would be intermediate AMD, and then definitely supplements at that stage, but still diet and other lifestyle factors as well.
Yeah. And there's a few people, so coming back to that question in terms of what we talked about, the quantity of zinc, presumably if anybody is taking anything that means that they ought to have a lower dose of any of the active ingredients of AREDS2, then it's possible to take each bit separately. So you could say, for example, cut out the vitamin E if you knew that there was a reason why you shouldn't be having high levels of vitamin E. I've put the quantities of what's in an ARIDS2 in the chat, and we'll add
Great.
that again before we end. We'll also add the link to our website, which has more of this information. So if you're worried you're taking something else, you're having a treatment for something else that means you shouldn't be having high doses of any of these, then it is possible to get the bits that you can have without having it in one formulation, isn't it, Tiernan?
Yeah, I think so. Yeah, like you say, if someone has a specific reason why you can't or you shouldn't take some component, I think the next best thing one could do is try and build it up individually. We don't have such good evidence, of course. The direct evidence we have just applies to people taking that particular
Yeah,
formulation. But yeah, I think you just do the best that you can do by building it up towards the closest you can to the ARIDS2 formulation.
yeah.
Yeah, that's
So,
key.
so I'm going to ask you a massive question, which I have not prepped you to answer, but what do you think is next to learn in terms of either diet and lifestyle and AMD, or, do you think there'll be an ARIDS 3 study? What should,
Right.
what can we look forward to in terms
Yeah.
of, things that are going to make life so much better and easier for everyone with AMD?
Gosh, yeah. No,
Sorry,
that's a big
massive
question. No,
question.
I mean, a few things come to mind. In terms of the link between diet and, and eye health and macular degeneration progression, I think it's probably doing a lot of different things. And then, of course, the intestinal microbiome, all the bugs that live inside our intestine, may be a really important part of that story. There are things like lutein zeaxanthin, and if they are effective, they're probably effective because they go directly to the macula. But there are other parts of our diet, or possibly even supplements, that are effective, not in such a direct way, but because they promote, a healthy gut bacteria that is in turn effective, in turn beneficial for the eye. So we're starting to learn about those kind of things, but I think we're just scratching the surface. So that's a massive area where we'll learn about. We are hoping to do an ARIDS3 study, hard to say for sure yet, but we are hoping to do that starting in the next couple of years, from the National Institute. So that would be another really large multi-center study. And I think, if we're able to launch that, there may be two parts to it. One of them would be, a bit like the story I was talking about at the beginning, trying to look at this question of whether supplements really do slow down the growth of geographic atrophy to the center. But then the other large part of that would be seeing if there are other parts of, oral supplementation that we can add in that would be even more effective. Maybe looking at people with early AMD where we don't have anything to offer yet, and seeing if supplements could be effective at that stage if we design the study appropriately. And then other kind of interesting things, like there's an unusual type of drusen called reticular pseudodrusen. We don't know exactly what that means in terms of supplementation. So it's still an early stage, but we are hoping to do that kind of thing in the coming years. It will take a while, of course, to
Yeah.
organize and for us to have the results of that.
Yeah,
Yeah.
and we at the Macular Society we have a research database that anybody can sign up to. So when fabulous researchers like Tiernan say we've opened a study, we can let people know how they can take
Oh
part in
yeah,
those studies.
fantastic.
I
Right.
mean, is that likely to be just in the US, or do you think it will be multi-country?
Yeah, so ARIDS 1 and 2 are just in the US,
Yeah.
but there are other networks like the DRCR Retina Network that expanded from the US to include Canada. We had a smaller study, the ARIS, which was including European studies, including in the UK. So I really hope that ARIDS3 would be able to take on European and UK centers, but not sure yet. Still at an early stage of planning.
No, but
Um,
we learn, don't we, from research that happens all over the world. So just, the fact that it may not happen in the UK doesn't mean that it won't be beneficial. So yeah, don't
yeah, no, I
don't
really hope
fret
that it
if it's
would.
US only.
Now, for various reasons, it would be fantastic if it could include the UK. And then the data are more representative of kind of, and we could even start to look into global differences if we were doing studies like that in different continents. In Asia, it would give us massive amounts of information. And the
Yeah.
only other thing else in terms of things on the horizon, I did some previous research quite a few years ago, and others are doing a lot at the moment, trying to look at the link or possible link between sleep apnea and AMD. And in my mind, it's actually quite an important and neglected link. So it's very underdiagnosed, obstructive sleep apnea. And in my analyses and in some recent analyses, it's quite an important risk factor at various different stages of AMD. So that's one other thing we may hear about more on the horizon.
I mean, my mind is blown a little that we would think that that's fascinating.
Yeah. And there are some biological reasons why it's, sleep apnea seems to increase oxidative stress and all of these kind of things. But yeah, and CPAP is not fun, but is effective. So anyway, that's just one other thing that came to my mind.
Yeah. Oh, well, we'll keep our eyes
Kind
on
of
that.
potential neglected risk factor. Yeah.
Yeah, yeah. Just going back a little, Michael Coleman has asked, you emphasize the AREDS2 and geographic atrophy. Is it as positive if you have neovascular as it is if you have GA?
Yeah. The short answer is probably not. And I didn't say too much about wet AMD, neovascular AMD, because yeah, the visual outcomes in neovascular AMD are almost entirely bound up with, firstly, how quickly you're diagnosed, how early or advanced the disease, the neovascular disease is at the time of presentation and first treatment. And secondly, the effectiveness of the anti-VEGF therapy. So anything else you do is likely to have only very kind of small incremental effects. So, and for that reason is much, much more difficult to study. So I've not done analyses looking at detail at what it means to have, supplements or no supplements in addition to normal anti-VEGF treatment for wet AMD, because I think once it's got to that point, it's almost all about the anti-VEGF therapy. Yeah, so no, it's a really good question. We don't have evidence in that area.
Yeah,
Sorry.
yeah. This has been so brilliant, and there's 302 of you, which is I think the most we've ever had on one webinar. I was joking with Tiernan earlier saying that he's knocked Ian Pearce off the top
Oh, I'm
spot.
sorry.
So everybody, thank you so much for joining us, Tiernan. Thank you so much for giving up your time. Everybody
Thank you.
else, have a fantastic couple of months, and we will see you back on the 21st of January.